had the power surgery last week, and then keep going. All right. So as we talked about last week, with case control studies, we typically have two kind of groups. We have cases and we have control. The cases are participants with the disease of interest. So say, for example, if you're studying cancer, your cases would be individuals with cancer. And then you would have controls, and your controls are participants without the disease. In this case, it would be patients without no cancer. So say, for example, we were doing a study that looked at tobacco smoking in adolescents, and we did a longitudinal study following them from adolescence all the way up until they were adults. And we were looking at whether or not they smoke and they develop lung cancer. Your cases would be individuals who develop lung cancer, and your controls would be individuals who did not develop lung cancer. Something of interest is that both cases and control are asked the same set of questions about their exposure. So as it would relate in terms of a longitudinal study of teens that started smoking when they were adolescents, and you were to follow them over a course of many years, you would ask them questions over the course of, in their past, how many packs of cigarettes did you smoke, et cetera, et cetera. This was the framework that that the book talked about as it relates to case control study. So the first questions that you want to ask when you're framing out a case control study is, what is the individual's current disease status? So is the individual's disease or non-disease? And so this situation would be the individuals with the cases or the individuals with cancer. This, in the adolescent example, would be the cases, and the individuals with no disease or no lung cancer after a longitudinal study period. Those would be your control. Then the other question you want to ask when you're thinking about a framework for a case control study is, did the individuals have the exposure at some point in the past? So in the past, did individuals smoke, which is the exposure, or did they not smoke, which is their non-exposure? And so the way that case control studies can, this is the traditional framework for the case control study. You could either be a diseased individual, as in you developed lung cancer and you did smoke. You could be an individual, a controlled individual, did not develop lung cancer, you did not smoke. You could also be an individual who did not develop lung cancer, you also smoke. And you can also be an individual who developed the disease, got lung cancer, and you did not smoke as well. So that's the basic framework for case control study. So let me go back over this again. So cases would be individuals who develop lung cancer. Controls would be individuals who did not develop lung cancer. So in terms of their exposure in the past, individuals who got lung cancer and smoked, that could be an exposure, so they did smoke, or they could be individuals who got lung cancer and they did not smoke, and so that's why this error C goes over here. When you think about controls, it could be an individual who did not have lung cancer and smoked, so they have some kind of exposure, and the control would be, and they also could have no disease and no exposure. All right. So how do you find case control studies, or how do you find case and control? All cases must have the same disease, so lung cancer as an example, disability or other health-related condition, as defined by the case definition. So if you're doing a malaria study, if you're doing a lung cancer study, your case definition, how do you define your cases? You would come up or you would determine before you come with your research study. You can say, okay, cases are defined as individuals who develop malaria, individuals who develop breast cancer, individuals who develop prostate cancer or cancer in general over a 10-year period. So that would be your case definition. You can find cases through hospitals, specialty clinics, physician's office, public health agency, disease registry, and disease support groups. And so this is how you can find your cases. Control. use a control definition to ensure that controls are similar to the cases except for the disease. So when you're doing case control studies, you want your cases and your controls to be very similar, except for the fact that the cases are the individuals with the disease and the control does not have the disease. Right? Find controls who are friends and relatives of cases, hospitals or clinic patients without the disease of interest or members of the general population. So that's how you find your controls. Match it. So there's three different options in case control studies. You can have no matching, so you don't match your case and your controls. You can have frequency group matching, so select one or more control per case who are similar by age, sex, and other characteristics. So the whole objective of the case control study is essentially to find out what happened in somebody's past that led them to a specific exposure. So as it relates to your case, did smoking cause you to develop lung cancer? And so you want to compare that individual to somebody else who did not smoke and probably did not have lung cancer. The individual who also did not smoke and also got lung cancer because there's some other environmental factor that impact the outcome, all right? So that's one way to match. Then you can do match pair. This is individual matching. Recruit a genetic sibling or other control who is linked to the particular case during the analysis. So as it relates to the lung cancer, say if you had twins, or siblings in the same house, the twins or the siblings in the same house started smoking at the same time, that would be a match pair individual matching. The book cautions to avoid overmatching. We talked about recall bias a little bit in another example, but essentially recall bias, or to be aware of recall bias, is when cases and controls systematically have different memories of their past. So essentially, one of the ways to limit recall bias is don't allow your study period, when you're asking people about past exposure, don't allow too much time to pass. So if you ask somebody, what happened to you 6 months ago? That's very difficult for them to go back and say, okay, 6 months ago, I was living in Athens, I was a student at UGA, and this is what happened. But if you were to ask somebody, what happened to me 2 weeks ago, that's very likely for you to remember an exposure that you had or an interaction that you had 2 weeks ago. All right? So recall bias is essentially when individuals have a difficult time of recalling or remember an exposure or something that happened in the past. So that was essentially case control studies. We're going to go now into our cohort study. And from the lecture from last week, the cohort study is the last part of that lecture, and then we're going to go into the lecture for today. All right. So a cohort is a group of similar people followed through a time together. So this class, your third-year pharmacy class, is a cohort of students. The second-year pharmacy class is a cohort. The first-year pharmacy class is a cohort. You guys are similar as it relates to characteristics. You're in UGA Pharmacy School. You're taking courses at the same time with a cohort of individuals. So you would be defined. Everybody in this class, in terms of the entire third-year pharmacy class, would be defined as a cohort. All right. All cohort studies are observational studies, so they don't have an experimental design. With at least two measures, with at least two measurement times, a baseline and a follow-up. So what this is saying is, when you're doing cohort studies, there's always going to be two assessments. There's going to be a baseline assessment, and then you're going to have another assessment at some point in the study period. So for example, same study, we're looking at cohort study. We're looking at individuals who smoked when they were teens and developed lung cancer as an adult. We have a cohort of 500 individuals who smoked as teens, and 250 of them developed lung cancer when they were adults, right? So at the baseline, when the study is enrolling, the study is beginning, we're going to ask them a couple of questions. Did you smoke? How many cigarettes did you smoke? What kind of cigarettes did you smoke? Baseline. Then we can say, okay, well, maybe at year 1 or 6 months from baseline, we're going to do an assessment again. And then we can do another follow-up assessment at year one, another follow-up assessment at year two. And so that's essentially what essentially defines a cohort study. There's always some kind of assessment done to observe. And so that's why it's an observational study. You're not doing an experiment. Okay, key characteristics of cohort studies. They could be prospective, as in you enroll individuals and you follow them going forward in time, or they could be retrospective, as in the disease happened and you find out what happened in their past. So retrospective, prospective. That's essentially, so objective, compare rates of new incident disease over time in people with or without well-defined exposure. So that's essentially the objective of prospective and retrospective controls. And then the primary study question, is an exposure associated with increased incidence of the disease? So because you smoke, was it associated with you developing lung cancer? This is the framework for cohort studies. So basic question one, did the individual have the exposure but not the disease at the start of the study? So did you have lung cancer when the study started? Did you smoke? I'm sorry. So did the individual have the exposure? So did the individual smoke when you started the study? So not the disease. Did you smoke? Right? So that's your exposure versus non-exposure. During the study period, did the individual develop the new disease? So did you develop, incident cases is essentially you're newly developing lung cancer, or you did not. So this is just a basic framework of you can go from exposure to disease, non-exposure to no disease, no exposure to new disease, exposure to non-disease. And there, as a researcher, there are a lot of factors that could impact you going from the various different elements. All right. Type of cohort study, and I talked about that retrospective study, recruitment based on exposure status at some point in the past, and use follow-up data from some point after the exposure to ascertain disease status. Prospective study, recruit based on exposure status in the present and follow participants forward in time. Longitudinal study essentially recruit a representative sample of a population and follow these individuals forward in time. So that's the difference in terms of type of cohort study. So one of the main things that I want you guys to take away from this is when you hear cohort study, it's essentially, it's an observational study that you're doing. You're doing some kind of observational study, and there are three different designs that you can do when you're doing cohort studies. This is just a basic timeline for the different kinds of stuff in terms of cohort study. So retrospective study is essentially, so you have retrospective study, prospective, and longitudinal study. So retrospective, this is the past here. So you start, this is where the study would start, and then you would go back all the way to the past to find out what happened in their past. So this is study entrance here, and you go back in the past. Prospective and longitudinal study is, this is your study period here, and you move it forward in time. Same thing with longitudinal study. That's just the basic timeline or follow-up period for cohort studies. Longitudinal studies may have a fixed population or a dynamic population with rolling enrollment. So a fixed population, if we were doing a study that looks at third-year pharmacy student, which is you, your population at the University of Georgia, your population is fixed because we're not going to admit any new, ideally, you're not going to admit any new students to this third year. This is the cohort of pharmacy students. There's a better example that I can use, and let's use that. So when the bomb was dropped, when the atomic bomb was dropped on Hawaii, and all that devastation happened, that's a very fixed. That's a fixed population of individual because that event happened to those individuals at that specific point in time of their life. It's not something where we can go back and add new population to that, add new individuals to that population, if that makes any sense. All right, another example, because I'm seeing faces that I can see where it's not making sense. All right, so fixed population. So for example, you guys just graduated pharmacy school, and all third year, all of you guys in this cohort decide we're going to go on a cruise. We're going to go on a cruise, and we're going to go to Jamaica, we're going to go to the Bahamas, we're going to go to Tahiti, we're going to go to England. That's a long cruise, right? Right? And there was a norovirus that broke out on this cruise, and a bunch of you guys got sick, right? That's a fixed population because it's unique to all of you guys who are on this cruise and all the locations that you went to, and that nobody else other than those individuals on that cruise would be able to be a part of that population. So that's why it's fixed, all right? As opposed to dynamic and open population. If we were doing a study wherein we were just looking at individuals who, if we were looking at individuals who were third-year pharmacy students who were, and I'm always going to use third-year pharmacy students, that's what you guys are, third-year pharmacy students who are getting the flu, right? This week, 30 you guys get the flu. Next week, 35 get the flu. The other week, 32 more get the flu. And so the population is constantly increasing, all right? Social consideration. Retrospective studies require a source of valid data about past exposure. So we need to know what happened in the past. Prospective and longitudinal studies must take steps to minimize losses to follow up when the study continues for many years. So loss to follow up is you enroll 300 people in a study, and then people go, okay, I don't want to be in your study anymore, or they move and or they die. So loss to follow up is essentially the 300 individuals that you initially enrolled. You know, fast forward a year, you might be at 390. You might be at not 390, 290, because you're losing participants. You're not gaining. You're losing individuals. All right. All right. Experimental study approaches. So that ends the lecture material for last week, and then we're going to talk about, for this week we have 17 slides. There's not a lot of content, and so for the next couple of minutes, we're going to talk about experimental study design. So as opposed to cohort study, which we're essentially just doing some kind of observation, with experimental study design, there's going to be some kind of manipulation, some kind of analysis, some kind of intervention that the researcher is going to be doing. So that's the difference in terms of cohort studies. We're just watching individuals. We're just observing. We're just trying to figure out what happened, as opposed to with experimental study design. There's going to be some classic example of experimental study design. You have a laboratory. You're doing some kind of experiments, you're changing something, you're adding chemical reagents. Most of you guys do organic chemistry 2, you're adding something, you're manipulating something that was over the course of your study, you're doing some kind of change or some kind of manipulation. All right, so the first thing that you want to know when experimental study approaches, is there some kind of causal relationship? So is there covariance or cause and effect? So did the fact that you did some kind of experiment, did that cause a result? So is there a cause and effect relationship? Okay, so there are 3 basic kinds of experimental design. There's non-experimental design, quasi-experimental design, and experimental design. For the focus of this presentation, we're going to focus on the book references quasi-experimental design, which is essentially a fake experiment. It's not a real experiment. And then non-experimental design is there no manipulation. There's no intervention that's occurring. And then, of course, the experimental design in which we're going to talk about. Experimental studies, you're essentially trying to figure out a causal relationship. You're going to do some kind of manipulation. You're going to do some kind of control. And then you're going to do some kind of randomization. The next couple of slides will go into manipulation, control, and randomization. So manipulation, the intervention. What will the intervention be? These are some of the questions you want to talk about, or you want to think about when you're thinking about the intervention or the manipulation for your experimental design. What are the eligibility criteria for participants? Where and how will the participants receive the intervention? How often are for what duration will participant receive the intervention. And so these are some of the baseline questions that you want to think about when you're thinking about developing some kind of intervention. In your experimental design, you can have controls, so conditions where individuals who are not receiving the intervention, so this could be your comparison group, and then there are kinds of control. These kind of control, I'm sure that you guys are well aware of, so you have like placebo, which is an inactive comparison that is similar to the therapy being tested. So for example, if you're looking at two drugs, if you're doing a study that has two drugs and you want to look at a study outcome, a placebo would be a fake or sugar pill in that example. There could be a standard control, so compare the intervention to some existing standard of care. If you were doing a study that looks at asthma, and you want to look at a new asthma therapy that is being brought to the market, you can compare that study medication to the current standard of care for asthma. And so that's essentially the standard. And then you can do active controls, comparing the intervention to some other care. So active control would be if you're looking at, say for example, you're doing an asthma study and you're looking at two new medications that are being brought to the market. You can do a comparison between study medication 1 and study medication 2. That is an active control. All right. Okay. Watch out for the Hawthorne effect. So what is the Hawthorne effect? Is it somebody playing an instrument? Is it something? Is it some kind of special power that you're receiving? No. Participants in both the active and the comparison group may change their behavior for better because they know that they're being observed. So, for example, if you're doing an asthma study and you have active patients in one group and the other group, because they're enrolled in a research study, they're changing their behavior because they know, okay, for the next 6 months, I'm enrolled in this research study, I'm getting an intervention, or I'm getting a stipend to be a part of this research study. So rather than them actually acting out their true behavior, they're changing the core elements of what they normally do on a normal basis. It's say, for example, if Dr. Young was to walk into this class, or you guys might change your behavior because he just walked into the class. That's the Hawthorne effect, right? All right. Randomization. Randomly assigned participants to group should result in equal group or balance of participants, reduced impact of confounding variables. So whenever you're doing a study, randomization is very important, and you want to make sure that individuals are randomly assigned to whether or not they're getting the active control or the placebo. So those are some of the things that you want to make sure. It has to be. You can't just, if I was to do a study and this is what is very common with health insurance, is that most health insurance, what do they want to do? Their number one thing is to maximize profit and to reduce paying out a lot of claims. So typically with most insurance, what they would like to do is they would like to enroll all healthy people into their insurance policy. That's not randomization. So say, for example, if I'm doing a research study and I want to look at a study outcome, I can't recruit and enroll all the best, or cherry pick, that's the common word that is used. I can't cherry pick the best research subjects and put them in the group and put them in one study, in one arm of the study, and give them the active ingredient, or give them the active drug. The active drug, of course, would be the study outcomes. Say, for example, I'm the pharmaceutical company, and I just spend billions and billions of dollars on creating this medicine for asthma. And I went out there and I recruited the most healthy children and gave all of them compared to individuals who are not as healthy in the study. And I gave all the healthy children my drug, and I said, okay, because at the end of the study it showed that my drug had, or the pharmaceutical company drug, had a superior control over asthma compared to standard of care or some kind of drug that is on the market. Well, you can't do that because one of the things that are going to confound your outcomes is it the fact that the children were healthier they probably didn't need their asthma or rescue inhaler more frequently compared to non-healthier children. So that's why that's why randomization is important. All right. All right, so this is figure 12-7, and it basically breaks down randomization into simple randomization. Each individual is assigned to a treatment group, so that's just a simple randomization. You can have block randomization, so in the simple randomization, individual 1, individual 2, individual 3, individual 4, different group. Block randomization, groups of individuals are randomized to treatment groups. So this is the block, this is the block, this is the block, this is the block, not individual. And then stratified randomization, individuals are grouped into strata and then randomized to the treatment or non-treatment. So this essentially here would be this essentially is one strata here. This would be, so I would do strata here, I would do a strata here, I would do a strata here, and a strata here. So you stratify and then you randomize. The other component is blinded, so you can stay blind. Participants are unaware of their exposure status. You can do double blind. Neither the participant or the researcher know which participants are in the active and the control group. Also, you want to think about your inclusion and exclusion criteria, specify characteristics of the target population. So when you're thinking about randomization, think about your inclusion and exclusion criteria as you're designing your study. There are types of experiments. So there's, just like I talked about before, there's a laboratory experiment. So that's where you're doing studies in lab. There could be a field study. So you're going out into the field. So the field could be a clinic. The field could be a classroom. You have natural experiments where things are happening in nature, and then simulation where you create environments to do your study. There's this other thing that you need to consider when you're thinking about experimental study. You have to think about validity, so internal validity, so internal and external validity. We're going to talk about those two next slide. So internal validity is, say, for example, I created a study back to asthma, and I want to know, is the study questions that I created for this asthma study, or is the research questions that I created for my asthma study, is it measuring what it's intended to do? So internal validity is how well does your study is measuring what you are intended for it to measure. That's essentially what the book is saying here. External validity for the asthma study is generalizability. So how well does the study outcomes is generalizable to the population at large? That's the difference between internal validity, which is looking at the study, how is the study mechanism, how is the study research question, how is the study instrument created, is it measuring what it's supposed to measure, as opposed to external validity, how can you generalize what you found in your study into, or to the population at large. There are threats to internal validity. So threats to have a study, create a study, you're trying to assess whether or not the elements you're truly measuring what the study is designed to measure. Selection, history is what is happening at the time. So if you have a study and you're looking at the flu vaccine, and you're looking at, is it fall versus spring? Are you more likely to get the flu in the fall or the spring? That's something that you want to consider as you're determining your mortality. So that could have an impact especially if you're studying this, especially if you're doing a study that looks at cancer patients and you're looking at treatment outcomes. If in one arm of your study, majority of your patients are dying as opposed to another arm, mortality can impact or has some threat to your internal validity. Right? Those are some elements. Threats to external validity, the interaction effect of testing, so external validity, so the individuals who are, this is essentially the Hawthorne effect as it relates to, so the individuals who are being tested, they're going to behave a little bit different than the overall general population who are not part of the research study. analysis. So you're doing your experimental study, and there are a couple of analyses that you can do. You can do treatment receive approach, so limit the analysis to the participants who are fully compliant with their assigned intervention. So if you're back to the asthma study, if you're looking at teens and you are compared to inhalers, you can say, okay, you're compliant, individuals are compliant, so you're going to limit your analysis to those individuals who are compliant with the study protocol. That's what you call treatment receive approach. Then you could have a treatment assigned approach or intent to treat approach. Includes all participants, even if they were not fully compliant with their assigned intervention. So same asthma study, you have individuals who are assigned new asthma inhaler or standard of care, individuals with the new asthma individual with the new asthma inhaler decided, okay, I'm only going to use this 3 times over the study period, but the study protocol asks for at least 10 or more times. You still intend to treat analysis. You would still approach the analysis as if that individual is not compliant, but as if that individual is still in that study arm. Right? So the next couple of slides is the final part of this presentation, and so we're just going to talk about just a few ethical considerations. Intervention studies raise special ethical concerns about the researcher, assigning participants to exposure. So, say for example, if I'm a pharmaceutical company and I'm a researcher and I'm looking at is my inhaler that I've been developing for the last years and years and years, I'm bringing to market, FDA finally gave me approval to do phase 4 study on humans. And I want to compare that inhaler to standard of care. Is there something ethical would I have some kind of ethical dilemma when I'm the researcher paying for the medication, doing the intervention, doing the research, as opposed to if somebody external from me was able to do the research study. So that's essentially an ethical consideration. There's this concept in a lot of medical school, a lot of medical journals, in a lot of journals related to healthcare outcomes is this concept of equipoise, right? And so essentially what it's saying is that don't bother to do research if you're going to put patients through a lot of, you're going to be drawing blood, you're going to be putting them through a lot of intervention. If you don't truly believe that the research has some kind of if you truly don't know whether or not the outcome is uncertain. So there's this concept of equipoise, and for the last 5 years, I've noticed that there's a lot of government agencies who, when you write and you submit grants, they want to know whether or not they don't want you to do research study or propose research study that we already know the outcomes to. So sometimes it's hard to get funding when you're doing a research study that does tobacco cause cancer. Like that's something that's well defined. And so as a researcher, you will have a hard time determining the clinical equipoise of your research study because we already know it's not as uncertain. We already know that that's a very certain outcomes. And so that's something that you want to bear in mind. Last slide. Examples of ethical issues in experimental study design. So the study topic, is the study really necessary? So that's equipoise. So is it really necessary to do? I'm just going to go through a few of them. Selection. Is an experimental design truly necessary for the research that you're doing? And then I'm going to talk about recruitment here. So is the source population an appropriate and justifiable one? Is the inducement to the participants appropriate, not to cause coercion? So inducement is if I'm recruiting you for a study and I'm giving you some kind of incentive, I'm paying you money for the study, it shouldn't coerce you to join the research study. It should be just a thank you for being a part of the study. And that's it for, this is the last slide, and that's it for today. Thank you.